This is the eye of a 68-year-old woman who had myopic LASIK performed approximately 20 years ago and now presents for cataract surgery. We found that the biometry performed by standard methods is accurate in terms of predicting the spherical power of the intraocular lens. However, calculating the astigmatic component of the required correction has proven to be trickier. And in this patient, we're going to do two things to try to establish the correct way to deal with whatever astigmatism might be present. And the first has already been done, and that is a total keratometry reading with the Zeiss IOL Master 700. And the second thing we're going to do is an aphakic refraction. That means that after we remove this cataract, we're going to leave the patient aphakic, and the patient will have a post-operative refraction done an hour post-operatively, but more importantly, the next morning, tomorrow morning, when the pupil is normal sized, another aphakic refraction. And we'll use that to calculate the power of the toric IOL, if any is required. So in this patient's right eye, I'm making a side port, and now a 2.4 millimeter clear corneal incision. This pupil is kind of mid-dilated, some lidocaine. Let's see what happens with viscode here. Now you can see the pupil getting larger. So this is a bit of a floppy iris, and that's from the amlodipine, Norvasc, that the patient's taking. Now I'm going to make an opening in the central anterior capsule. And now fixating the globe with the spatula while I do the capsulorhexis makes it safer to do it. Calcium channel blockers do give you a moderate floppy iris, not as much as Flomax, for example, does, but somewhat floppy. So let's complete this rhexis following the curvature of the sphincter. Now a hydrodissection by lifting up the anterior capsule and injecting. There's the fluid wave, nucleus came forward, pushed it back down. Same thing on this side, push it back down. I'm going to do 180 degrees of viscodissection with the viscote now. Distal 180, that's the nasal part, of course. Let's test infusion, and not good on the left. Turn the sleeve and it became good. There's the Mackool big ball curved sharper. Quadrant. Sculpt. So let's sculpt down and get a red reflex. I can see a bit of one already there. A little deeper, and now we can chop it. Quadrant. Oh, just completing the chopping here. Back to sculpt. I'll change that quadrant. So I'm listening for the tone to get up there and then step on the pedal when I hear high vacuum. And that reduces the amount of ultrasound that we have to use here to remove the nucleus. And the last two segments here coming up. White the cornea. Good. Here's our last segment and protecting the posterior capsule with the chopper posterior to the level of the phaco tip, just in case there's an infusion misdirection syndrome. Last little piece here, take that and a little buzz. So now INA, test infusion, it looks good. In we go. Now there's a little chip over here, and I'm going to take that. My advice here is take them early during INA when you know where they are, because they can disappear and then you're searching around. Remove them at the beginning. So here goes cortex removal with a 90-degree INA tip. And I'm kind of protecting the posterior capsule here with the spatula underneath the INA tip. This is a bit of infusion misdirection here. That posterior capsule is a bit more forward than usual, just so common. So I'm not going to let the posterior capsule get to the INA tip. And that's a 0.25 opening port. What cornea? And that's a safer port. If you happen to catch the capsule, it's much less likely to break it than a 0.3 port. So now we'll go in and put some hyaluronic acid-based OVD into the posterior chamber and just clear a couple little opacities off the posterior capsule there, filling the posterior chamber. I'm going to hydrate this incision a little bit, tighten it up, and then I'm going to irrigate the OVD out and leave the patient aphakic for the aphakic refraction that we discussed earlier. Stromal hydration disappears in about 20 minutes, so it won't affect the aphakic refraction. It will be done in 1 hour, and then again in the morning with a normal pupil. Can't emphasize that enough. So this is the next day, and we've decided to place a toric IOL at a meridian 35 degrees, so we've marked it. Intraocular lidocaine, the pupil still doesn't dilate well, of course. Now injecting OVD into the posterior chamber, and the iris will enlarge a bit here. We'll expand that posterior chamber for IOL insertion. And here goes our toric IOL. We'll inject it, and as it goes in, it's going to be close to the correct meridian, just happenstance. And I'm going to leave it a little shy of that 35-degree axis. And that leading haptic hasn't released, so we'll watch it for a few seconds, and if it doesn't release, and it hasn't, so I'm going to go in with a capsular rhexis forceps and just grab the terminal bulb and squeeze it, and that always releases it. So our next step here is to remove OVD, and I'm going to go behind the IOL by nudging it to the side and put that 90-degree tip under it, put the port facing upward. That's the safe way to do it. And there goes the OVD from behind the IOL. And then from in front, line that IOL up. There's still some OVD in the anterior chamber here. So I'm going to stromal hydrate, close these incisions. I see that there's a little bit of a wispy cortex behind the IOL, probably of no significance there, but I think I'm going to try and aspirate that here in a minute. Let's just seal these incisions first. And very important when you want to go behind the IOL here, go in injecting fluid. I'm injecting fluid now and injecting fluid, so I displaced that little piece and it floated around there. This first slide shows the aphakic refraction performed in the morning of the second day. In other words, when the pupil was normal size. And we can see it's a typical high hyperopic correction. But there's 1 diopter of cylinder at 130 degrees. And if you go back to your basic optics, that translates to about 1.4 diopters at the corneal plane. And that would be 40 degrees where the steep meridian is. So according to the aphakic refraction, we should place an implant that corrects 1.40 diopters at the 40 degree meridian. Looking at the next slide, we can see that the Zeiss IOL Master 700, the total keratometry, meaning the anterior and posterior corneal curvatures, add up to 1.36 diopters at 32 degrees. So nice to see that the aphakic refraction and the total keratometry, or TK reading, are very, very similar. The axis is different, however. We had 40 degrees in the manifest refraction and 32 degrees with the total keratometry. So what to do? And this slide shows what we did and the result. So we went right in between the 32 and the 45 degrees and selected 35 degrees as the axis in which to place a 1 diopter correction, which would very slightly perhaps undercorrect the cylinder that we measured. And 2 weeks postoperatively, the patient's uncorrected visual acuity was 20/25, improving to 20/20 with a refraction of plano minus 50 at 100 degrees, indicating that we did leave intentionally a bit of astigmatism. The axis shifted somewhat from 35 degrees to 10 degrees, is where the steep axis would be there. And that's probably because of a little bit of surgically induced change from the 2.4 millimeter clear corneal incision. So this is currently my technique for trying to establish the amount of astigmatism that exists in eyes with previous laser vision correction procedures, such as the myopic LASIK that this patient had undergone, and the rationale for doing both total keratometry and also an aphakic refraction.